A 5-year-old child presents with marked bowing deformity of the leg. I'm showing you the radiograph of the lower leg. Describe the findings.
Let me just study this for a second. Right. The anteroposterior radiograph of the lower leg demonstrates marked angulation deformity of the mid-to-distal diaphyses of both the tibia and fibula. There is nonunion of the bony fragments with tapering, cupping, and pencil pointing of the bone ends, representing a well-established pseudarthrosis. The bones also show generalized osteopenia, and there is narrowing of the fibular shaft. The appearance of congenital bowing progressing to fracture and pseudarthrosis is highly characteristic of neurofibromatosis type 1.
What is the differential diagnosis for tibial bowing and pseudarthrosis in a child, and how do we distinguish them?
The differential diagnosis includes neurofibromatosis type 1, osteogenesis imperfecta, fibrous dysplasia, and nonunion of a simple traumatic fracture. In neurofibromatosis type 1, bowing is classically anterolateral and associated with a hypoplastic fibula, focal cortical narrowing, and sclerosis. Osteogenesis imperfecta usually presents with bilateral involvement, multiple fractures of varying ages, and exuberant callus formation. Fibrous dysplasia displays a characteristic ground glass density lesion at the apex of the deformity. Traumatic nonunion lacks the syndromic signs of neurofibromatosis or osteogenesis imperfecta.
I'm showing you the follow-up post-fixation radiograph. Describe the findings and the surgical approach.
The follow-up anteroposterior radiograph shows that the child has undergone corrective osteotomy. There is alignment of the tibial and fibular segments, stabilized with an intramedullary rod and pins. Bone grafting has been performed at the pseudarthrosis site to promote solid bony union. Corrective osteotomy, internal fixation, and bone grafting are the standard surgical treatments for established tibial pseudarthrosis, as conservative management with bracing is usually ineffective once a fracture has occurred.
Discuss the underlying pathophysiology and other osseous manifestations of neurofibromatosis type 1.
Neurofibromatosis type 1 is an autosomal dominant disorder caused by a mutation in the neurofibromin gene on chromosome 17. The tibial bowing and pseudarthrosis are caused by localized hamartomatous fibrous tissue invading the cortex and medullary canal, which thins the bone and prevents normal healing after microfractures. Other key musculoskeletal manifestations include severe, rapidly progressive scoliosis, thinning of the ribs, scalloping of the posterior vertebral bodies, sphenoid wing dysplasia, and multiple non-ossifying fibromas or subperiosteal bone cysts.
How would you manage this patient as a radiologist?
As a radiologist, I would recommend comparing these radiographs with prior studies to evaluate the degree of bowing progression or post-surgical hardware stability. I would recommend obtaining a dedicated MRI of the lower leg to evaluate the extent of soft tissue neurofibromas and the viability of the surrounding musculature. I would immediately communicate any signs of hardware failure, infection, or non-union to the orthopedic oncology and pediatric teams. I would also suggest checking for other clinical signs of neurofibromatosis, such as café au lait spots, Lisch nodules, and axillary freckling.